Good morning, everyone, and welcome again to the Pathology for Pharmacy course. This is Dr. Maram Abdaljaleel, and this is our first lecture. In this lecture, we will be covering diabetes mellitus. Let's start.
Let's start with a brief review of the endocrine pancreas. The endocrine pancreas consists of the islets of Langerhans, which contain four major cell types: beta, alpha, delta, and the PP cells or the pancreatic polypeptide cells. The beta cells. The beta cells produces insulin, which regulates the glucose utilization in tissues and reduces the blood glucose levels. The alpha cells. The alpha cells produces glucagon, which raises the glucose levels through its glycogenolytic activity in the liver. The delta cells. The delta cells secretes the somatostatins, which suppresses both insulin and the glucagon release. The PP cells that secretes the pancreatic polypeptides, which exert several gastrointestinal effects, such as the stimulation of the secretion of gastric and intestinal enzymes and the inhibition of intestinal motility. The most important disease of the endocrine pancreas is the diabetes mellitus, caused by the deficient production or the action of the insulin. Diabetes mellitus is a group of metabolic disorders characterized by hyperglycemia. Hyperglycemia in diabetes results from defects in insulin secretion, insulin action, or most commonly both. The chronic hyperglycemia and the metabolic abnormalities of the diabetes are often associated with secondary damage in multiple organ systems, especially the kidneys, eyes, nerves, and the blood vessels. That's why diabetes is considered the leading cause of end-stage renal disease, adult-onset blindness, and the non-traumatic lower extremity amputations in the United States. Blood glucose levels are normally maintained within a very narrow range, ranging from 70 to 120 mg per deciliters. According to the American Diabetes Association and the World Health Organization, the diagnostic criteria for diabetes include the following: a fasting plasma glucose greater than or equal to 126 mg per deciliter, and/or a random plasma glucose greater than or equal to 200 mg per deciliter in a patient with a classic hyperglycemic signs, and/or a 2-hour plasma glucose greater than or equal to 200 mg per deciliter during an oral glucose tolerance test with a loading dose of 75 grams, and/or a glycated hemoglobin level, hemoglobin A1C, greater than or equal to 6.5%. All tests, except the random blood glucose test in a patient with a classic hyperglycemic signs, need to be repeated and confirmed on a separate day. Many acute conditions associated with stress, such as the severe infection or burn or trauma, can lead to transient hyperglycemia due to the secretion of hormones such as catecholamines and cortisol that counteract the effect of insulin. So the diagnosis of diabetes requires persistence of hyperglycemia following the resolution of the acute illness. Impaired glucose tolerance or prediabetes, on the other hand, is defined as a fasting plasma glucose between 100 and 125 mg per deciliters, and/or a 2-hour plasma glucose level between 140 and 199 mg per deciliter during an oral glucose tolerance test, and/or hemoglobin A1C level between 5.7% and 6.4%. Why this is important? Because as many as 1/4 of individuals with impaired glucose tolerance will develop diabetes in the next upcoming 5 years. With additional risk factors such as obesity and family history, the risk will be compounding. In addition, individuals with prediabetes have an elevated risk of cardiovascular disease. This table shows the simplified classification of diabetes, of which we will be discussing the type 1 diabetes, type 2 diabetes, gestational diabetes, and the pancreatogenic diabetes. Type 1 diabetes. It accounts for approximately 5 to 10% of all cases. It's an autoimmune disease characterized by pancreatic beta cell destruction and an absolute deficiency of insulin. And it's the most common subtype diagnosed in patients younger than 20 years of age. Type 2 diabetes. Approximately 90 to 95% of diabetic patients have type 2 diabetes, and many of them are overweight. In type 2, it's caused by a combination of a peripheral resistance to the insulin action in one hand and an inadequate secretory response by the pancreatic beta cells, which we call the relative insulin deficiency, on the other. Although classically this condition is considered an adult onset disease, the prevalence of type 2 diabetes in children and adolescents is increasing, and this is due to the increasing rates of obesity in these age groups. Regarding the pathogenesis of type 1 diabetes, type 1 diabetes is an autoimmune disease in which islet destruction is caused primarily by immune cells reacting against endogenous beta cell antigens, and this is due to the failure of self-tolerance in beta cells. Most patients with type 1 diabetes depend on an exogenous insulin for their survival. So without this insulin, they may develop serious metabolic complications like ketoacidosis and coma. Although the clinical onset of type 1 diabetes is abrupt, which I mean as sudden, it results from a chronic autoimmune attacks on beta cells that usually starts years before the disease becomes evident. The classic manifestations of the disease, such as ketoacidosis, happen late in the course, after more than 90% of the beta cells have been destroyed. As with most autoimmune diseases, the pathogenesis of type 2 diabetes involves genetic susceptibility and environmental factors. The strongest genetic association is with the class 2 major histocompatibility complex HLA-DR genes. Between 90 to 95% of white patients with type 1 diabetes have HLA-DR3 or DR4 or both. Type 2 diabetes is a heterogeneous and multifactorial complex disease that involves interactions of genetic, environmental risk factors, and inflammation. Unlike type 2 diabetes, however, there is no evidence of an autoimmune basis. The two defects that characterize type 2 diabetes are a decreased ability of peripheral tissues to respond to insulin, which we call insulin resistance, and beta cell destruction that is manifested by an inadequate insulin secretion in the face of insulin resistance and hyperglycemia. The first defect that characterizes type 2 diabetes is insulin resistance, which is defined as the failure of target tissues to respond normally to insulin. The major tissues involved are the liver, skeletal muscles, and adipose tissue as the following. Failure to inhibit the endogenous glucose production, which is called the gluconeogenesis in the liver, which contributes to the high fasting blood glucose levels. And then abnormally low glucose uptake and glycogen synthesis in the skeletal muscles following a meal, which contributes to the high postprandial blood glucose levels. Then the failure to inhibit hormone-sensitive lipase in adipose tissue, which leads to excess circulating free fatty acids, which also exacerbate the state of insulin resistance. Few factors play an important role in the development of insulin resistance as obesity. The second defect that characterizes type 2 diabetes is beta cell dysfunction. While insulin resistance by itself can lead to impaired glucose tolerance, beta cell dysfunction is an essential component in the development of diabetes. Beta cell function actually increases early in the disease process in most patients with type 2 diabetes, mainly as a compensatory measure to counter the insulin resistance and to maintain normal blood glucose levels. Eventually, however, those beta cells are unable to adapt to the long-term demands of the peripheral insulin resistance, and the state is switched from the hyperinsulinemic state to a state of relative insulin deficiency. Clinically, the onset of type 1 diabetes is marked by polyuria, polydipsia, and polyphagia, which are known as the classic triad of diabetes, and in severe cases, ketoacidosis can happen. All are resulting from metabolic derangements. However, in the initial 1 to 2 years after the manifestations of type 1 diabetes, which is referred as the honeymoon period, exogenous insulin requirements may be minimal because of the residual insulin secretion. But eventually, the beta cell reserve is exhausted and exogenous insulin become essential to control the hyperglycemia. Although beta cell destruction is a gradual process, the transition from impaired glucose tolerance to over diabetes may be abrupt, and this is heralded by an event associated with increased insulin requirements, such as infections. Type 2 diabetes, on the other hand, also may manifest with polyuria and polydipsia. In some cases, medical attention is sought because of an unexplained weakness or weight loss. Most frequently, however, the diagnosis is made after routine blood or urine testing in asymptomatic individuals. The acute metabolic complications of diabetes include diabetic ketoacidosis. In patients with type 1 diabetes, especially with significant deviations from the normal dietary intake, unusual physical activity, infections, or any other forms of stress may worsen the metabolic imbalance, leading to diabetic ketoacidosis. Symptoms are quick and include nausea, vomiting, abdominal pain, fruity odor to the breath, fatigue, weakness, and shortness of breath. Due to the absolute insulin deficiency and the unopposed effects of the counter-regulatory hormones, mainly epinephrine and glucagon, the plasma glucose level ranges between 500 and 700 mg per deciliter. This results in osmotic diuresis and dehydration. Osmotic diuresis is defined as the increased urination rate due to the hyperglycemia. The second major effect of this hyperglycemic state is the activation of ketogenesis. Insulin deficiency leads to activation of hormone-sensitive lipase, resulting in an excessive breakdown of the adipose stores, resulting in increased free fatty acids, which are oxidized by the liver to produce ketones. The ketones can be used as a source of energy for consumption by vital organs like the brain. But if the rate of ketones production exceeds the rates of utilization by the peripheral tissue, this may lead to ketonemia and ketonuria. Ketonemia is defined as high concentration of ketone bodies in the blood. Ketonuria is the presence of ketone bodies in the urine. And if the urinary excretion of ketones is compromised by the dehydration, the accumulating ketones decreases the blood pH, resulting in metabolic acidosis, so this is what we call diabetic ketoacidosis. The second acute metabolic complication of diabetes is the hyperosmolar non-ketotic coma. It's a metabolic emergency that occurs usually in the decompensated states in patients with type 2 diabetes. A wide variety of focal and global neurologic changes may happen in those patients, including lethargy, coma, delirium, visual changes, sensory deficits, and seizure. In the decompensated states, patients with type 2 diabetes may develop hyperosmolar non-ketotic coma. This syndrome is characterized by severe dehydration resulting from sustained osmotic diuresis and urinary fluid loss due to the chronic hyperglycemia. Typically, the affected individual is an older adult who is diabetic and disabled by a stroke or infection and unable to maintain adequate water intake. The absence of ketoacidosis and its symptoms like nausea, vomiting, and respiratory difficulties delays the recognition of the seriousness of this situation until the onset of severe dehydration and coma. Chronic complications of diabetes. The morbidity associated with long-standing diabetes results from: first, the chronic complications of the hyperglycemia itself, and then the related damage induced in both large and medium-sized muscular arteries. This damage includes macrovascular disease, which causes accelerated atherosclerosis, resulting in increased myocardial infarction, stroke, and lower extremity ischemia, and also microvascular disease that affects mainly the retina, kidneys, and peripheral nerves, resulting in diabetic retinopathy, nephropathy, and neuropathy, respectively. The morphologic and clinical features of chronic diabetes. Let's start first with the pancreas. Clinically, the patient presents with symptoms of hyperglycemia. Morphologically, one or more of the following alternation may present. In type 1 diabetes, for example, a reduction in the number and size of islets can be identified. Also, leukocytic infiltrate in the islets, which we call insulitis, and usually it's type T cells or type T lymphocytes. This figure shows the histologic view of an autoimmune insulitis in a human pancreatic explant. The green arrow points to the inflammation surrounding islets of Langerhans, while the surrounding acinar structures are essentially normal. Type 2 diabetes, on the other hand, may show amyloid deposition within islets, in and around capillaries, and between the cells. Similar lesions may be also found in older non-diabetics as a part of the normal aging process. This figure shows the histologic appearance of the amyloidosis of the pancreatic islets in a patient known for type 2 diabetes. Amyloidosis typically is observed late in the natural history of this form of diabetes. Although there are main differences between diabetes type 1 and type 2, similar long-term sequelae of both type 1 and type 2 diabetes due to the uncontrolled or poorly controlled hyperglycemia, and those are responsible for much of the morbidity and mortality in diabetic patients. The complications may appear 15 to 20 years after the onset of hyperglycemia. Of those are diabetic macrovascular diseases. The hallmark of diabetic macrovascular disease is accelerated atherosclerosis, affecting the aorta, large and medium-sized arteries. Myocardial infarction caused by atherosclerosis of the coronary arteries is the most common cause of death in diabetics. Gangrene of lower extremities is about 100 times more common in individuals with diabetes than in the general population. So myocardial infarction, renal vascular insufficiency, and CVAs, which is the cerebrovascular accidents, are the most common causes of mortality in long-standing diabetics. Diabetic microangiopathy is another complication. It's characterized by diffuse thickening of basement membranes in the capillaries of the skin, skeletal muscle, retina, renal glomeruli, and renal medulla. Despite the increase in the thickness of the basement membrane, diabetic capillaries are considered leaky, leading to extravasation of the plasma proteins. This underlies the development of nephropathy, retinopathy, and neuropathy. Another chronic complication of diabetes is the increased susceptibility to infections, mainly skin infections, tuberculosis, pneumonia, and pyelonephritis. In an individual with diabetic neuropathy, a trivial infection in a toe may be the first event in a long succession of complications like gangrene, bacteremia, pneumonia, and this may ultimately lead to the death. As previously discussed, type 1 and type 2 diabetes are distinct pathophysiologic entities with common manifestations of hyperglycemia. This table summarizes some of the clinical, genetic, and histopathologic features that distinguish the two diseases.